quite a while now. Is there a specific device or technology that stands out to you?
I remember seeing the microscope for the first time, and it really is breathtaking. Just a different way of engaging visually the surgery. Hard to really describe in words, but just the feeling of immersion of the image, and I would say relaxation simultaneously with the immersion in a way that I'm just relaxed and looking at surgery rather than the more rigid posturing that we've had to conform to just with the current technology mechanically linking back to the last 100 years or so. This is a refreshing new take on what ergonomics should be, both for comfort of the surgeon and their health going forward, as well as their efficiency and ergonomics being able to deliver the best for the patient.
What do you see as the points that make innovation stick compared to those points that make innovations go away after a few years?
Certainly more of them have gone away than have stuck over the years.
Yes.
I can't help but reflect back on one of my friends and mentors, Charlie Kellman, that brought phacoemulsification surgery into the world. And it was one of the first developments outside of the academic medicine for which he was questioned very aggressively by academics and powers that be, and how could this procedure possibly be valid? It wasn't developed within the confines of academia, and he was persecuted in many ways for pursuing it. He had an autobiography that's, I think, still in print called Through My Eyes. It's worth reading. Any surgeon, anyone in medical technology, to document his struggles at bringing what is now very much a standard of care and has been for decades into being. And he had a saying that I think is apropos to your question, and that was that, while doctors debate, patients decide. And patients will decide based on what they like. It wasn't hard for them to decide. Friends that had standard extracapsular cataract surgery with multiple sutures and needed cutting over a period of months with poor vision and discomfort, versus the patients that had even early phacoemulsification. Typically, incision was closed with a single stitch, minimum astigmatic aberrations, vastly more comfort, wound integrity. Patients talked. They decided. It didn't take relatively long. In Charlie's mind, probably too long, but it quickly became the standard of care. And I think that those sorts of efficiencies in terms of patient outcome, patient comfort, patient performance of addressing their pathology, addressing their symptoms, and I think those technologies that efficiently deliver that end result to the patient in the most comfortable form possible, while simultaneously allowing the surgeons to deliver it in an ergonomic and efficient fashion, are the ones that are going to stick and flourish.
Are there any guiding principles for you when you look at a new technology or when you innovate a tool yourself that you try to follow?
My own thoughts are relative simplicity, looking at a problem on its basic elements. I would give Elon Musk a little bit of credit here when he talks about fundamental principles, or basic principles thinking. And he, to his credit, doesn't take credit for it. He talks about having been a paradigm in physics for many years, but originally stemming from Aristotle, looking at problems being broken down into their fundamental elements rather than looking at an issue in terms of its current iteration, which most likely represents multiple attempts at guiding that problem to where it is now that may or may not have been right decisions. So the example he looked at, of course, was battery production. And rather than go to Toshiba or Panasonic and try to analyze, well, how do they build a battery? He looked at a battery and said, well, what are the fundamental elements it's composed of, and what does it cost on the spot commodities market to purchase those elements? Now I have these elements, here's their cost. How can I put these together to make a battery? And he started from those fundamental principles and was able to achieve economies of scale and production that were heretofore unreachable because he simply looked at a blank slate. And so I find that approaching problems like that and ignoring current iterations often are the most fruitful. An example is an eyelid speculum that when I was using them and we were doing retrobulbar blocks, there wasn't much of an issue in terms of patient comfort because they couldn't feel anything. But as we transitioned to various forms of topical anesthesia, certainly Jim Gills deserves tremendous credit for that advance, it was obvious that we often weren't anesthetizing the lids. Patients were feeling the discomfort of their eyelids being stretched open by prior arch speculums, and seeing that then allowed me to wonder, well, what's going on? And what happened was the lids, the speculums weren't functioning in an anatomically correct fashion. If we look at eyelids from the side, we can see that they're curving over the globe and like a visor over a helmet. And yet every speculum that was created up until that point was opening in a plane or a frontal plane. And so they weren't respecting the natural anatomic curvature. So development of a speculum, rather than me looking at all the speculums that were out there that were all operating in a fundamentally incorrect fashion, instead, it was easier to reverse engineer the anatomic movement of the eyelids, which was simply an arc, following an arc over the globe. And then to design a mechanical linkage, it simply supported that arc of movement. And it ended up being by prior standards, a somewhat complex instrument, only because it had some compound curves, they had to have ball joints to be able to follow that, but in so doing allowed an instrument that actually respected the curvature, gently opened the lids following that arc of curvature, much more comfortable for patients, less likely to produce a disinsertion of the levator. Lid ptosis can be a complication of surgery, and it seemed reasonable to assume that part of that might have been this distortion of the eyelid anatomy during normal opening by a speculum that was opening in the wrong plane. So a very long answer to your question about approaching a problem by looking at fundamental principles reasoning. What is really the element of the problem and what would make sense to address it?
We have more and more patients, more and more aging patients. We have fewer surgeons, fewer ophthalmologists, staff shortages. Costs are increasing everywhere. Reimbursement is going down. What's the role of innovation that you see in helping us address all of these issues?
Because of what you've described, which is unlikely to change and rather to continue in that fashion, innovation has to include efficiencies, not only in terms of what we've discussed up until now in terms of surgeon ergonomics and rapid recovery for patient, but there have to be cost efficiencies in order for doctors to continue delivering care to patients. And those inefficiencies, I believe, are being addressed by technology that seeks to integrate functions that are currently disparate, spread among multiple different machines in terms of real estate, in terms of staffing, in terms of patient comfort. And by integrating those into more concise units, I think we're going to get benefits not only in economics, but also in clinical efficiency.
You've mentioned cataract surgery, Dr. Kalman, and it's one of the most frequently performed surgical procedures globally. So inefficiencies in the cataract workflow play a major role. Now I'm very curious to hear from you, where do you see inefficiencies in the cataract workflow?
I think they're manifest now in multiple areas, but all the more so as the bar has been raised in terms of the outcome, in terms of refractive outcomes and refractive lens implants and patient expectations. And it's complicated the workflow because of the extra detail, the extra granularity that's now spread among it, that begins not with the biometry, but of course before that with the patient exam, with the patient history, the intake. What are the patient's problems? What are their goals? What do they want to achieve and what do they want to avoid? And all of this has to go forward into the biometry. In fact, it drives the biometry, just like patient's chief complaint drives the exam. This drives the whole surgical procedure, the surgical journey, in terms of what do we look for, what do we need to make sure they have and don't have. A patient may want a full range of vision without glasses. Well, in order to achieve that, we'll, in current technology, consider a diffractive multifocal lens that has inherent into its design some reduction of contrast sensitivity in order to give that enhanced range of vision. Well, and if the patient has contrast sensitivity that's optimized in the absence of other pathology, then that's a reasonable choice. But we would want to integrate that into an efficient workflow such that we've identified the goal, and are looking for elements that might interfere with that goal. For example, anatomic signs that might reduce contrast sensitivity. We would want biometry that identified a suspicious nerve that might be previously undiagnosed glaucoma. We'd want biometry to accurately look at RPE abnormalities that might represent subtle early drusen, potential for macular degeneration that might also decrease contrast sensitivity. We want to accurately assess the cornea, looking for abnormalities that might represent non-orthogonal astigmatism, asymmetric astigmatism, irregular astigmatism, and is it regularly irregular, consistent among multiple images, or irregularly irregular, changing with each blink over different images, which gets to another inefficiency of our workflow that depended in some offices not on any topography, and then many others a single topography, not looking at what are those variations. So all of these are potential landmines that we have to navigate around in order to not be surprised, and of course for the patient not to be surprised with an outcome. How do we either intelligently address these issues as identified by biometry that are driven by the initial history and exam? How do we address them in terms of either correcting the pathology or correcting the choice of lens addressed to that patient as identified by the workflow, including the efficient biometry?
So switching gears for a moment, many technologies are looking to improve outcomes. How important is that last part when you are evaluating technologies that they're either gonna increase revenues or decrease cost for your practice?
I think you have to look at it in mostly a global fashion, to the extent that we have an increasing aging population, we have a decreasing number of providers. And toward that extent, with increasing cost, technology has to address the issue in terms of allowing the providers to take care of this increasing aging population in an era of decreasing reimbursements. There's certainly an element of macroeconomics whereby Adam Smith might say that even with a very expensive technology that patients feel there's a value to and they think is worth it, that perhaps it will survive, but it's a more difficult road to do that, and it may be a minority of the population that chooses it, and hopefully we will have continued innovations like that offer a choice. But I think that for the bulk of our aging population, being able to deliver a premium, accurate, cohesive choice and workflow and providing them better vision, I think is going to be an invaluable commodity that iQity is offering.
When you heard about iQity's mission, which is to helping ophthalmologists deliver better outcomes while reducing cost and saving time, what resonates with you?
The big resonance is simply the integrity of the company. It's hard not to admire that as a driving force in a company, to genuinely want to not only bring out a great product, but to genuinely want to address the global issue of getting that care to the 100 million plus patients that desperately need it and are having a progressively more difficult time in obtaining it. I can't help but admire and appreciate it, and looking forward to using the instruments as soon as you can get them out.